Good evening, friends. Thank you, Dr. Sharad Sheth, for your kind words, Chairman, Dr. Brother, and thank you, Dr. Mahapatra and Dr. Manoria for this kind introduction and asking me to speak today. That slide. When Dr. Manoria rang up and asked me to speak, he said, please speak on kidney transplantation in diabetics. Now, ordinarily, I would at least need 30-40 minutes to speak to the non-nephrologists, physicians. But having been assigned 12 minutes, I will try my best to select what I feel that what every physician should know about kidney transplantation in diabetics. So I have listed 7 FAQs. I have listed 7 FAQs, which are common asked by physicians of me, and in which the data and substance that I speak of is useful for you to be able to guide your patient who is waiting for the CKD stage 5 to strike him, what should be the best option. Because here is a patient who has come to you with a creatinine of 4.5 and 5 with T1 or T2 diabetes. And the question is asking is that should I go for what form of renal replacement therapy? So my first slide shows you that although this is a slide only for T1, but T2 is very similar. And in this slide, you see that between dialysis and living donor kidney transplant for the T1 diabetic, there is a 10-year life difference and quality life years of about 5 to 6 years. So if a person with type 1 or even type 2 gets a living donor kidney transplant, that is the best option for his life. And in the past, if the history of transplantation is taken, you will see that people were denied transplant in the early stages of CKD development and RRT development. Transplant was actually denied to patients of diabetic nephropathy, and only dialysis was available to them until the pioneers in America and England agreed to try out and found excellent results. And since then, things have changed. Now, in type 1, of course, we do the pancreas after kidney transplant, and also we do this pancreas together simultaneously with kidney transplant. So that data is also on this slide. But the two important data are the first and the last. You see that quality life years are very useful, and therefore even for the older transplant patient, older patient, and many of our patients are above 60 and 65. Today things are changing, and when cadaveric transplant is available, then we are looking at about 5 years extra. If we can give a 65-year-old another 5 years, we are happy to do that for him. And good quality 5 years or 6 years. You see that deceased donor is a cadaveric donor. So today our attitude towards transplanting even older donors, and the funny thing is that most of our cadavers which come to us, Dr. Sharad Sheth will agree, are old patients. And all the organ transplant distributing societies, the legal providers of the organs give preference for the older recipient if the patient's, the deceased donor or the cadaver is old. So if I receive a 65-year-old cadaver of a person who had cerebral hemorrhage or brain tumor, then I'm happy to give it to an older person rather than give it to a 19-year-old boy, because I know that the life of that kidney is a little less. And so the societies and the organ transplant distribution systems give preference to older transplant patients. So next slide, please. So that's my first point. Now this shows you that between the 3 mortality, of course, there is mortality. There is no question of mortality. And the highest mortality is, of course, in type 2 diabetes. And next is type 1. And the non-diabetic has the best mortality, least mortality. But we are looking at a disease which is ultimately mortal. So it doesn't really matter. This is worth taking on. Next. And we have, next one, not one. Graft failure. You see, the graft lives almost equally whether the patient is non-diabetic or type 2 diabetic or type 1 diabetic. So the grafts survive long. The patient generally dies of some other complication. The diabetes comes back. The hyperglycemia, which has disappeared, comes back with a vengeance. People get infections, bad chronic infections, urinary infections, and of course, coronary artery disease, which is very important. So the mortality which you see after transplant is not so much graft failure as much as comorbidities hurting the patient and the consequences of immunosuppression. So you look at the second FAQ is when you do transplant in diabetics. The important point I want to emphasize here is the earlier onset of uremic symptoms in diabetics. The non-diabetic with CKD will require renal replacement therapy approximately when the GFR is 5 ml per minute. The diabetic, however, will require it much earlier when the GFR is 10 or even 15. So many people with 15 GFR with diabetic kidney disease will opt and go for and be even subsidized in the American system at 15. The government pays for transplant. And the equivalent creatinines would be that a non-diabetic usually goes on to 10, whereas a diabetic has a creatinine of 6 to 8, is usually very symptomatic and needs dialysis and transplant. Finally, serum creatinine, I must point out, is a poor indicator of GFR due to less muscle mass in the diabetics. And the uremic symptoms overlapping with diabetic symptoms, you can see here that uremia and diabetes mimic each other. There is gastropathy, uncontrolled hypertension, unresponsiveness to diabetes of the edema and the pulmonary edema, neuropathy, which comes with both, pruritus, prurigo, impetigo, all very common in both, protein dysmetabolism, congestive heart failure, and immune deficiency. Therefore, diabetes with diabetic kidney disease and CKD are a double whammy, and we must act early. That is my second point. So the third FAQ is, what are the options available in diabetics in CKD stage 4 and 5? The 5-6 things that I must present to my patient when he comes to me with GFR of 20 is that I must put a fistula very early. Whether I'm going for transplant or not, fistula is to come first. That is called fistula first. Because whether I do transplant or not, there is a good chance, even after transplant, that the kidney may fail and I may go back. So putting a fistula is yesterday's job, not today's, not tomorrow's, but yesterday's. Early preemptive hemodialysis is also very important. It is important that the patient should not be allowed to deteriorate into severe uremia. And hemodialysis done preemptively gives the patient a better quality of life. Selected cases may go for CAPD. However, having said that, CAPD in India has been a regular failure, unfortunately, for various reasons I can't discuss. On the other hand, the most important thing, and I'm very happy that 4 cardiologists, I hope the surgeon and all are listening, cardiac assessment on coronary revascularization is mandatory before transplantation. If we cannot do that, and then following transplant, the patient needs surgery or angioplasty, that is disaster. So every patient of diabetic kidney disease going for transplantation must go for cardiac assessment. Now, preemptive transplantation is another way of acting. That is difficult for the diabetic. I will explain to you why. But if one is lucky to have a living donor available, and many people do have, then one need not wait for uremia to set in. You must do the dialysis only once or twice just before the operation. Before that, prepare everything, get the donor ready, and do a preemptive transplant. It is an exceptionally better way. And of course, the final is doing transplantation after starting dialysis. Now, as I come back to the cardiac, this is the 4th FAQ, that can we go ahead with transplant in a patient who has cardiac abnormalities? And the answer is absolutely no. And I've explained why. Now, what are the tests available to me? Of course, resting ECG, exercise stress test, stress echocardiography or non-stress dobutamine echocardiography or nuclear stress, nuclear non-stress dipyridamole, percentin thallium, you see here that all these are not perfect. Their sensitivities and specificities are not perfect, and we are going to miss some amount of coronary artery disease prior to transplant. Next slide. And therefore, this is my algorithm, and an algorithm most of us follow pre-transplant for cardiac evaluation. You put the patient and classify the risk and ask whether this is low risk, intermediate risk, or high risk. Those who are on dialysis are automatically high risk, because it is better to go straight for cardiac catheterization than waste our time for all this stress echo, etc., etc. However, a cardiac catheterization, if you do it preemptively, if you are doing the transplant preemptively, you might unnecessarily. So immediate score, risk score, and this flow diagram are very important. And if necessary, the patient should have cardiac catheterization and intervention. Next slide. Now, the next FAQ is how to select living donor or diabetic nephropathy patient in ESRD. The most important thing is, if the donor is diabetic, do not take him. And you know how to make out who is diabetic. So I won't go into that. Next. The kidney donation by people with pre-diabetes. This is very important. He asks, can I be a kidney donor if I have pre-diabetes? And the answer is maybe. And we have to look at him carefully. Next slide. And this is how we assess the assessment of a risk for diabetes mellitus. With if a donor, living donor, wants to give and there is some doubt. And this flow diagram is available to you for you to read whenever you feel like. Next slide. Now, final question number 6. Can I donate kidney to my relative who has diabetic nephropathy? Parent, yes, but then parent is likely only in type 1. Hardly will you see a diabetic with a parent young enough to give a kidney. Once the donor is 60, 65, we don't take donors. Sibling, yes, but only if he is non-diabetic and has crossed the age at which the diabetic sibling whom he is donating to has developed diabetes. So if the patient developed diabetes at 45 and he is now being transplanted at 55, a sibling who is 50, who has crossed that age of 45 and is clearly non-diabetic, should be allowed to donate. Children, absolute no-no, because the excellent chance that they will get. Spouse, yes, and that's the most common donation. Next, and these are my last 2 slides. What about getting a cadaver which is diabetic? Very often people with cars going fast, head injury or cerebral hemorrhage or tumor in the brain which is not spreading, these come as cadavers to us. So we look at whether they have macroalbuminuria or not. Now, this is called a marginal donor, and the recipient must be made aware that the diabetic injury of the kidneys is often seen even when there is no obvious diabetic nephropathy. And if you do this biopsy of that kidney, you will find early changes of diabetes. So when you decide to, in the past, people never took it. And this last slide of mine will tell you about a unique experiment that was done by Dr. Abuna in Kuwait 40 years ago. Next, last slide. And this is what Abuna did. He received 2 kidneys from a diabetic who had got into head injury and died. And he was in 2 minds what to do. And he did a biopsy on the table of the kidneys before transplanting them. And this was on the left side. The kidneys were showing early diabetic nephropathy. He transplanted into 2 people. One of them succumbed subsequently to non-diabetic disease. I don't know why he died, but came for autopsy, and he did the kidney biopsy of that transplanted kidney. And you see the left side had clear nephropathy, right? There is some nephropathy, but much less. So what it means is that when you take a diabetic kidney and put it in a non-diabetic person, you have an excellent chance that you may not create further damage, you may actually reverse the damage. And this experiment has been now reproduced by giving rats streptozotocin and then taking that diabetic kidney of the rat and putting it in the non-diabetic rat. And lo and behold, after sacrificing the kidneys, sacrificing the animal for after 6 weeks, you find that the disease becomes less. So putting the kidney in a non-diabetic internal milieu helps. Now, of course, it's a difficult question. We are often in our two minds, and many times such kidneys are lost. But with the paucity, next slide, with the paucity of organs that we are facing, we are using all possible marginal donors. And I'm sure that Dr. Sharad Shet will also share this with you, with us, his experience when kidneys are offered, which are diabetics, what to do. So with that, ladies and gentlemen, I hope I have conveyed to you some information which is of use for you to deal with people who are getting ready to do transplant and their families. Thank you.
And I think time has come wherein we try to enroll more and more patients with simultaneous kidney pancreas transplant. I think in Mumbai, if we do that, I think our patients will go forward and get uplisted and get organs a little faster than doing in diabetic kidney disease. Well, I welcome Dr. Sangram Biradar for his comments, please.
Thank you, Dr. Kriplani, sir, for your extensive coverage of the topic. What are the takeaways for the patients of diabetic patients? What do you want to say when they want to subject for diabetic transplant patients? Take-home message for the diabetic patients, sir.
Well, the take-home message is that transplant is better than dialysis, and do it early. Don't wait till you get sick. And if you get sick, you will be more difficult. And go with a good heart. Means first feed my surgeons and then feed me, or my interventionalists and then feed me. That's the take-home message.
Yeah, in this COVID era, any of your experience in this COVID with diabetic patients of kidney diseases, transplants?
Well, you know, the experience is mixed. There was a learning curve. Transplants have restarted. People are doing well, but people are doing few because only last week I had one kidney was offered to me and my patient said, no, I'm diabetic. And I think he was right. I said, do you want it? I'll do it. He said, no, I don't want to take a chance. So there are few, and those which are being done are usually living related, mother to son, people who cannot wait. You know, a poor man, a clerk's son, his wife is donating to his child. They can't wait. But diabetic will say, no, why should I take this cadaver kidney? It might be COVID, it might be anything. So generally, the COVID has brought about a selection of cases and reduction in numbers, and only those which cannot wait are being pushed through. That's my experience. Sharad, what do you feel?
I agree, totally agree. And again, I will repeat when I introduce you as a speaker, that you have a great knowledge and great wisdom, and probably your word is the last word. And I again repeat it.
No,
Thank you.
Thank you.
We're learning a lot.